Welcome back to Falcon Physician Review's online review for USMLE Step 1. This is Module 32 where we're going to talk about DNA non-envelope viruses. We're going to talk about adenovirus, papovavirus, and parvoviruses. These are ubiquitous viruses. They can live in the environment and we pick them up without human-to-human transmission, although they certainly can be transmitted that way, and they cause a lot of disease. We'll go through each one so that you can be familiar with it and be confident when you take them on Step 1. Welcome to Falcon Physician Review's online review for USMLE Step 1. This is Microbiology, Module 32. We'll talk about DNA non-enveloped viruses. The three species of DNA non-enveloped viruses we have to worry about are adenovirus, double-stranded DNA, papovavirus, double-stranded DNA, and parvovirus, single-stranded DNA. Adenovirus is a double-stranded DNA virus that's stable in the environment. It's resistant to low pH, bile, and proteolytic enzymes. This allows it to replicate in the GI tract. It has fiber proteins which bind to host receptors and act as hemagglutinins. Transmission is through respiratory droplets, through fecal-oral spread through the GI tract, and outbreaks in residential institutions and in summer camps. Adenovirus can cause an upper respiratory disease in kids in all seasons. It can cause a pharyngitis with or without conjunctivitis. It causes acute respiratory disease, ARDS type 1 through 7. Types 4, 7, and 21 may cause pneumonia in infants, military recruits, and those who are immunocompromised. Types 40 and 41 can cause infantile non-bloody diarrhea. This is a picture of adenovirus with its nucleocapsid core. Clinical findings depend on the tissue being involved. The eye can be involved in epidemic keratoconjunctivitis. This can happen when patients are having foreign particles removed from their eyes, and they get these viruses and then get an infection from there. You can also get a pharyngoconjunctivitis or pink eye, which is non-purulent. In the respiratory system, you get types 4, 7, and 21, which can cause the common cold, acute respiratory disease, or pneumonia. The GI tract can be infected with infantile diarrhea, types 40 and 41, and intussusception, or hemorrhagic cystitis in the urinary tract system with type 11. Lab diagnosis is based on viral isolation and culture. We do a shell vial and conventional culture. The cells that are infected swell and round up in grape-like clusters. They can also clump together. If you don't have time to do cell culture, you can do a rapid detection with ELISA, or immunofluorescence antibody, or you can do PCR for viral DNA. The treatment is often supportive. We don't have anything that will directly inhibit this viral production. Question. A 6-year-old boy presents with respiratory disease, pharyngitis, and epidemic keratoconjunctivitis, and gastroenteritis. The most likely offending pathogen is. So this poor unfortunate 6-year-old boy got adenovirus in his lungs, in his throat, in his eye, and in his GI tract. Adenovirus is the one that's going to form most of these things. And if you don't have any other distinguishing characteristics like inclusion bodies for CMV or vesicles for chickenpox, you're going to go with adenovirus as the most common cause of these. Parvoviridae is our next group, and it's single-stranded DNA. It's a naked icosahedron. Parvovirus B19 is pathogenic for humans, and it infects erythroid precursors. The epidemiology is we get it through the respiratory route, you can get it through blood products, vertical transition mother to child, in late winter and spring, with the highest incidence of 4 to 7 years old. Parvovirus causes fifth disease, which is erythema infectiosum. You're contagious before the rash appears. You have an incubation of 6 to 18 days, and you have a mild fever. You'll often show up with a lacy reticular rash that starts on the face. It has a slapped cheek appearance. After 2 to 3 weeks post-exposure, you have a drop in the hematocrit, and you can get reticulocytopenia because parvovirus infects erythroid precursors. Adults can have arthralgia and arthritis. Aplastic crisis can happen in sickle cell patients or those with thalassemia. Treatment is you give infusion of red blood cells if they're anemic. You can give passive immunoglobulin to absorb excess virus. If you have a congenital infection, you'll often get non-immune hydrops fetalis. If you're immunodeficient, you can get a pure red cell aplasia and from bone marrow suppression. Diagnosis of fifth disease is based on serology, and you use IgM. If you have acute arthritis, that'll also show up with IgM. Aplastic crisis shows up with the serum PCR. Red cell aplasia also through serum PCR. To diagnose hydrops fetalis, you have to get amniotic fluid and fetal blood PCR. Question. A 5-year-old girl presents with fever, rash, with a characteristic lacy reticular pattern and a slapped cheek appearance. The pathogen is most likely. So we're talking about fifth disease, we're talking about parvovirus, and so we're talking about a single-stranded DNA virus. So the answer is A. Next question. A 12-year-old boy with a documented history of sickle cell anemia develops fever, fatigue, pallor. Serial hemoglobin values are 10, 8, and 6. Leukocyte cell count is 7, and the platelet count is 375,000. The clinical picture of aplastic crisis is most likely to be produced by which of the following viruses? This is important to remember that parvovirus affects red cell precursors and is an important cause of aplastic anemia. So parvovirus is the answer. Hepatitis virus, herpes virus, and adenoviruses do not cause aplastic anemia. Papillomavirus and polyomavirus are non-enveloped, circular, double-stranded DNA. They have icosahedral capsids, and they're implicated in carcinogenesis. Papilloma causes human warts and cervical cancer. Polyoma has the BK and JC virus, and also the VA, a simian vacuolating virus, which does not infect humans. Human papillomavirus is the common cause of plantar warts, with subtypes 1 and 4. It can also cause condyloma acuminatum in types 6 and 11, and laryngeal papillomas for 6 and 11. You can get cervical intraepithelial neoplasia with types 16 and 18, also 31 and 33. Transmission for HPV is skin-to-skin and genital contact. The pathogenesis for HPV includes infecting squamous epithelial cells. Then you get viral oncoproteins E6 and E7, which collectively cause the cell cycle dysregulation, and also neoplastic transformation of squamous cells. Then you get koilocytosis, a change in the epidermal structure, and you get a benign condyloma or you get a carcinoma. E6 binds and promotes dysregulation of P53. E7 binds and antagonizes RB, so you get the P110RB. Lab diagnosis is usually a DNA hybridation test. It's usually diagnosed clinically, however. Somebody comes in and they've got viral warts. You have a good idea of what the cause is. You can get koilocytic cells on a pap smear. Treatment is podophyllin for genital warts, salicylic acid for plantar warts, liquid nitrogen for skin warts, and you can do a vaccine newly available for 11 to 26-year-old women for types 16, 18, 6, and 11. This is thought to decrease the incidence of cervical cancer caused by HPV. Polyomavirus has two main characteristic viruses we want to know about. BK viruses happen in immunocompromised hosts. They cause renal disease, such as hemorrhagic cystitis and tubulointerstitial nephritis. There's no known HIV association, and you diagnose it by cytology or biopsy. JC virus is seen in AIDS patients presenting with hemiparesis, hemianopsia, and cognitive deterioration. It causes PML, or progressive multifocal leukoencephalopathy. It targets oligodendroglial cells in the brain, and the brain biopsies show demyelination with abnormal giant oligodendrocytes and eosinophilic inclusions. The CSF exam is normal, and you diagnose it with PCR. Question. 35-year-old male patient with HIV/AIDS developed impairment of memory as well as deterioration of intellectual power and orientation. Brain biopsy specimens showed foci of demyelination surrounded by bizarre giant astrocytes containing intranuclear inclusions. Viral damage to the oligodendroglial cells of the brain were suspected. The most likely pathogen is... So again, this is just what we talked about. BK virus affects immunocompetent people. It causes problems with the kidneys, hemorrhagic cystitis, and tubulointerstitial nephritis. Whereas the JC virus is going to be your HIV/AIDS immunocompromised patient, and they're going to have PML, or progressive multifocal leukoencephalopathy. And the answer is A. Wrapping up Module 32, we talked about adenovirus, which is a common cause of conjunctivitis, epidemic conjunctivitis, and also pharyngitis. Look for it in military recruits and also college freshmen who live in the dorms. People who are in close quarters with each other have a good chance of spreading this to each other. Parvovirus causes Fifth disease, and also B19 is important to remember for aplastic anemia. We talked about human papillomavirus as a frequent cause of cervical warts and also cervical cancer. We're very glad that we have a new vaccine where we can treat sexually active young women to prevent them from getting cervical cancer. Next up, we're going to go to Module 33 where we talk about negative sense RNA viruses.